Today I want to talk about 5 years of multicenter experience with the CatchView device, over 600 patients. To give a brief photo explanation of our center, here you can see the view above of our hospital, which is located in a small forest area in the Anatolian side of Istanbul. On the right side, you can see our angio suite, and at the bottom, of course, most importantly, our team photo. To speak about our center experience, we are a comprehensive stroke center in the Anatolian side of Istanbul since 5 years, and since then we have increasing numbers in terms of endovascular thrombectomy. Now we are performing between 200 and 300 thrombectomy per year since 2 years, and also we have affiliated hospitals where we train fellows on thrombectomy. And all techniques are applicable in our center: balloon guiding with stent retriever, adapt technique, and combined approach depending on the patient's anatomy and the operator's choice. So despite the increasing frequency of the adapt technique, stent retrievers are still widely used as a primary revascularization method by many centers, and its portfolio consists of a wide range of options. Here you can see our thrombectomy shelf, but lately we mostly prefer CatchView device. And why? Because it simply works. It was launched in January 2018. Among the common features with other stent retrievers, I think 3 features are important with the device, which are smaller delivery system compatibility. All maxi sizes are compatible with 21-inch micro catheter, even 6x50 mm stent retriever. Diverse sizes covering all possible scenarios. You have wide range of options to cover all types of clots, and of course enhanced visibility thanks to its platinum and tantalum markers impregnated into stance profile. We share our experience with the device. The study was conducted on 53 patients. It was used as a primary instrument with balloon guiding catheter in 31 patients and was used as a rescue therapy with the adapt technique in 22 patients. Here you can see the demographic features of the patients, and we achieved a TQ2C3 recanalization close to 68%. There were 3 distal emboli, which all of them were successfully recanalized with the mini device, CatchView mini device. Favorable outcome at 90 days was 43%, and mortality rate was 13%. So I want to share a couple of patients with you. To start with, the first patient is 84 years old female, right hemiplegic and aphasic, an age score of 19. Here you can see a tortuous ICA anatomy, so the choice was to put a long sheet together with the distal aspiration catheter. Please note here the filling defect, a huge filling defect, which indicating a high clot burden in this patient. So we bypass the occlusion, selective microcatheter injection, and we deploy CatchView Maxi 6x50, which is, I think, important, up from MCA level to down to the ophthalmic geno level. So we take all the clot at once thanks to its length, because there are also publications showing that longer stent retrievers enhance recanalization rate. So with first pass, with the longest device available in the market in Turkey, you can take the clot at once. Another example, 72 years old male, left hemispheric symptoms this time, an AH of 17. In this patient, the preference was balloon guiding with sole stent retriever technique. Despite 3 times attempt, we couldn't recanalize the patient, so we are all familiar with the dual stent retriever technique. There are a couple of techniques available to perform in a Y stenting fashion or in a parallel fashion. In our center, we perform thrombectomy under local anesthesia, so it's difficult to perform Y stenting. We catheterize each branch, each MCA branch separately, and we simultaneously deploy both stents and take them out under aspiration. With the first attempt with dual stent retriever technique, I think both of them were 6x40. They were again the long ones, and we achieve, after the first attempt with dual stent retriever, we achieve TQ2C recanalization rates. And what about tandem lesions? We all treat them, but there is still no consensus about 2 issues. Should we start to recanalize intracranially or extracranially, or is the first issue, and the second one is, should we stent the ICA in an emergent fashion? These two studies are important in that terms, I think. This was published last year, is the analysis of German stroke registry. They compare retrograde and antegrade approach, and they clearly demonstrate that retrograde fashion, recanalizing first intracranial vessels, is related to better functional clinical outcome. And the second one is, I think it was 3 or 4 months ago, published in Journal of Non-Interventional Surgery. It was actually a meta-analysis. They also revealed that despite the increase in symptomatic intracranial hemorrhage rate, stenting the ICA pathology is related also with better clinical outcome. So our approach is the same. We first recanalize the intracranial part, and then if there is hemodynamic necessity or the ICA pathology doesn't seem well, then we put the ICA, we put ICA stent in emergent fashion. An example of a tandem lesion, 63 years old male with right hemispheric symptoms, NIH of 17. Here you can see a huge filling defect at the ICA bulbus, very slow antegrade flow. So we bypass it under balloon guiding aspiration. Then we make a selective injection in the subpetrous level of, okay, we have again a high clot burden patient. So we bypass the occlusion again from MCA down to the ICA supraclinoid ophthalmic level and take 6 by 50 millimeter stent retriever under balloon guiding aspiration. And here you can see the fish we take out. To check if we cause any distal emboli, AP and lateral shows, we fully recanalize the intracranial part. And then how to deal with the extracranial part. Our approach is to put a distal protection filter. Here you can see the video. After placing it, after opening the distal protection filter, we slowly take the balloon guiding or long sheet backwards up down to a common carotid artery under aspiration, because we don't want to cause any distal shower emboli. So we have distal protection filter, and while taking it backwards, we are performing aspiration. And after that, injection from the common carotid artery. It seems okay, AP and lateral. So in this patient, we have thrombus in the extracranial part, but which is not a big issue. There is no problem with the ICA, so we decided to leave it like that. And we inflate the balloon again, and we take the distal protection filter out under again aspiration. Then final check if everything is okay, AP and lateral shows sticky 3 recanalization. What about distal thrombectomy? I think they are important because they cause 25 to 40% of ischemic stroke patients, and these cerebral territories supplied by these vessels, although relatively small, can be remarkably eloquent. And considering that TPA cannot provide recanalization in 1 to 2/3 of these patients, intervention is needed thanks to advancing technology, which enables us to reach more distal vessels, because as the profile of the instruments used during access decreases, the complications may also decrease. So, considering that all the data, all the published data lately are defining TK2C and 3 as a successful recanalization rather than TK2B, so distal thrombectomy is gaining importance. We also shared our experience with the distal thrombectomy from M3, A3, and P3 segments via our 13-inch microcatheter delivery system. It was the same in all patients. 9 patients were treated with 11 distal thrombectomy maneuvers with the same combination, CatchV Mini and or 13-inch microcatheter. It was headway duo 167 centimeters in length. There we performed 6 distal thrombectomy from M3, 4 from A3, and 1 from P3. Successful recanalization was achieved in all patients, and the rate of good clinical outcome was 55%, so it works. And how we do it? We are all familiar with the pinching technique. We deploy the stent retriever centralizing the thrombus. Then we confirm the exact localization of the thrombus while the stentotuber is deployed in an unsubstructed view. Then we partially resheet the stentotuber towards the proximal end of the clot. And here you can see we pinch the clot between the stentotuber and the microcatheter, and we take both of them out under continuous aspiration. An example, 74-year-old male, left ICA occlusion. The preference was in this patient was the ADAPT technique. Here you can see the distal aspiration catheter already in the MCA, but lateral reveals that we have distal emboli at the ipsilateral A2, so we bypass it, deploy CatchView Mini, and take it out. As you can see here, the clot is clearly pinched between the stentotuber and the microcatheter. I think it's the key factor for success for distal thrombectomy, and lateral shows full recanalization of the occluded artery. This is another patient, 82-year-old male with loss of consciousness. Lateral vertebral artery injection shows we have thrombus at the mid-basilar and occlusion of the top of the basilar. So for posterior stem strokes, our approach is always aspiration. It's not like that in anterior circulation, but for posterior, we aspirate the clot. And after first pass, we achieve recanalization in the basilar artery, but we have new distal emboli at the right PCA P3 segment. So we decided to go there and deploy CatchView Mini 20 millimeters in length, and a big fish we take out from the P3 segment. And control angiogram shows recanalization of the occluded posterior cerebral artery. And another interesting patient, 86-year-old male, right hemispheric symptoms. In this patient, we have long sheet distal aspiration catheter here in place. So we deploy CatchView Maxi 6x40 millimeters in length, the longest one that was available at that time. So after first pass, AP seems okay. We have the recanalization in the MCA, but lateral shows we have distal emboli through the fetal PCOM at the posterior cerebral artery territory. So we decided to take it out. It sometimes can be tricky because performing these procedures under local anesthesia is sometimes challenging. Somehow we stabilize the patient head with the help of the nurse or the technician. We already passed the clot. Here you can see the stagnation with the microcatheter, and we will deploy CatchView Mini 10 millimeters in length. After stabilizing it, we start to deploy the stent. Yes, we achieve the antegrade flow now. And after that, as I mentioned, we make a contrast injection under unsubstructed view. We will see the exact location of the clot. Here you can see it. I think it's clear. So what we do, we partially resheet the stentotuber. We will see now. Up to the proximal end of the clot. Then after resheeting it, so somehow we pinch the clots between the stentotuber and the microcatheter, and we take both of them out under distal continuous aspiration. Lateral injection shows full recanalization of the posterior cerebral territory. And sometimes, unfortunately, we don't use stentotubers just for thrombectomy. Sometimes we use it for to solve the problems that we create. This is an elective patient with a family history, with a subarachnoid family history, subarachnoid hemorrhagic family history of the patient. 63 years old female with an unruptured A1 aneurysm. It's located, it's ugly shaped, located in the posterior wall of the A1 segment. So I think it's challenging both surgically and endovascularly. There are a couple of options, of course, to treat this aneurysm. It's not clear here, but the left A1 is hypoplastic. You can come from the contralateral side, and catheterization maybe is more smooth. There is no enough place, I think, in the proximal A1 to deploy flow diverter, which can be also a choice. So we decided to coil it. Okay, we have the balloon in place at the orifice of the A1 So we get inside the aneurysm, as you can see, and we started to coil the aneurysm. It was 2x4, something like that, or 2x3. First loop is outside, okay, no problem. The second loop, and while continue coiling, despite very gently, we behave very gently, but oops, the coil is out of the border of the aneurysm, make an injection, and we solve the rupture, immediately inflate the balloon. So, of course, we have no choice rather than continue coiling. Okay, we coiled. We slowly deflate the balloon a bit and make a control injection. Everything seems okay, but we wanted to be sure that we seal the rupture point fully. So the microcatheter was in place, so we decided to add some liquid embolic inside the aneurysm to patch the hole fully. So at that point, we deflate the balloon. We put it, of course, in the A1 to prevent reflux to anterior cerebral artery territory. But despite the inflation of the balloon, during injection, we noticed some black things here at the A1 territory. So we understand that we have the problem. We have the reflux in the anterior cerebral artery territory. Deflating it a bit, thanks to CatchView Mini, which is also can be deployed through double lumen balloon. We deploy CatchView Mini as it acts like a distal protection filter now. So we deploy it, and we have distal aspiration catheter here. We take both of them out, and here you can see the part that we take out from the A1 segment. At that time, we were happy. Okay, we fixed the problem. We have no problem with the ruptured aneurysm. We have no problem with the A1 segment, but unsubtracted view shows we have also something here in the MCA territory. While taking taking the stentor tuber out, I think we have new emboli at the MCA territory. So we go again there with the stentor tuber, this time with microcatheter. We have this aspiration catheter in the MCA and take the MCA liquid embolic out, and control injection, AP and lateral shows everything is okay. The patient discharged without any problem. She's fine. So it was an interesting patient. As a conclusion, based on our experiences with the device, with the CatchView device, we believe it's an effective tool in mechanical thrombectomy, providing safe recanalization with good clinical outcomes, and it can be used as both primary instrument with balloon guiding catheter or rescue therapy in the ADAPT technique. And for distal thrombectomies, with its lower system compatibility, I think CatchView Mini is substantial. So, gracias. Thank you.